My name is Antonio Sergio Marcelino. I'm from São Paulo, Brazil. I work as a radiologist specialized in ultrasound. I will talk a little bit about complications of liver transplants, normal and pathologic findings, and a multimodality imaging approach. Complications of liver transplantation, multimodality imaging approach. I will talk and we're gonna see some usual and unusual cases of complications of liver transplantation. Learning objectives. We describe the main complications of liver transplantations, demonstrate different examples of these complications and the main ultrasound Doppler criteria for vascular complications with multimodality correlation. Identify the appropriate indications for the use of contrast-enhanced ultrasound for liver transplantations, and discuss the use of ultrasound in this scenario and perspectives for contrast-enhanced ultrasound. In summary, the liver transplant is indicated in patients with end-stage acute or chronic liver disease. There are at least 3 kinds of transplants: the whole liver, split liver, and living donor liver transplantations for adults and children. Ultrasound. Ultrasound is the initial imaging modality. It can be performed in bedside scenario. In our hospital, we developed a protocol studying the patients in the 1st, 3rd, and 5th post-operative day of liver transplants. And with it, we can perform the detection and the follow-up of early and delayed complications. Normal findings of liver transplantations. Portal vein. The flow in the portal vein can be a spiral flow, continuous flow, or with respiratory variations. This is a continuous flow of portal vein, flow with respiratory variation. The hepatic veins and IVC. The flow is multiphasic in some cases, and we can be attempted to loss of triphasic flow, or when you find continuous flow in some situations, because these findings can be present in some cases of stenosis of the hepatic veins, as you can see later. Hepatic artery. 45.6% of patients presents with high resistance flow up to 72 hours post-transplantation. There is a relation with prolonged cold interval and donor age. There are no relation with early or late survival rates in 5 years. This is a flow with high resistance flow in the first post-operative period and a normal flow 3 days of follow-up. Complications. There are many complications such as hepatic artery thrombosis or stenosis, in the portal vein, hepatic veins, and in the inferior vena cava, biliary tree, rejection, neoplasia, and reinfection by viruses B and C. When you suspect of biliary complications, we can perform MRI or conventional cholangiography. In Doppler ultrasound screening, if you have a suspicion of portal or hepatic vein complications, MRI, CT, or conventional angiography can be performed. If we don't identify no flow at Doppler and we have a suspicion of thrombosis or hepatic artery stenosis, the contrast-enhanced ultrasound can be used to identify the hepatic artery in these cases. If you find a normal arterial flow, we do the follow-up of these patients. If you can't identify the arterial flow, we can do the angiography or MRI angiography or CT angiography. If normal, this patient goes to the follow-up, and if abnormal, it can be performed a treatment. Portal vein complications. The portal vein stenosis, the incidence varied from 1 to 19%. It can be asymptomatic, hepatic dysfunction, or portal hypertension. The diagnosis of ultrasound Doppler: an increased velocity flow on the stenosis, 3 to 4-fold increased velocity related to pre-stenotic site, a post-anastomotic dilation, portal hypertension signs. In this case, we can see a high velocity at anastomotic site on Doppler, a velocity about almost 20, 30, 100. And on Doppler, and we can see anastomotic portal vein structure here. On MRI angiography, we can see the structure of the portal vein, the dilation of post-stenotic site, some varices, and in this case we can see the stent inside the portal vein. Case 1 of portal vein stenosis. It's a 8-year-old boy with a 19-day follow-up of liver transplant, and we can identify a portal vein lung structure at grayscale and Doppler. Here is the grayscale lung structure of portal vein, and at Doppler the stenosis, a lung stenosis of the portal vein. There are many collaterals from portal vein at coronary vein site here, and collaterals at coronary vein site and communications with portal vein branch, in this case, as you can see here. It's a video showing the collaterals from portal vein at coronary vein site, and here the communication with portal vein branch. This is the treatment developed by Carnevale, and it's a minimal laparotomy approach. These are the collaterals at coronary vein site, the portal vein stenosis, the balloon inserted in the portal vein with the stent, and the treatment with the stent in the main portal vein. The follow-up 3-day post-stent, we can identify the stent in the main portal vein. There are no structures now. Normal velocity at post-stent portal vein. The collaterals identified, there are no flow in these collaterals now and a post-stent patient. The intrahepatic collaterals from coronary vein with no flow too, and it's a little bit faster, but here you can identify normal flow at the portal vein and no collaterals flow at coronary vein site. Here we can see the main portal vein, the stent inside the main portal vein, and the left branch of portal vein. Here. Hepatic vein complications. The incidence is less than 1% of transplants. It's more common in living donor liver transplants and children. Early stenosis can be caused by liver rotation, anastomotic size discrepancy, and delayed stenosis can be caused by fibrosis, thrombosis, and neointimal hyperplasia. On a grayscale ultrasound, we can identify pre-anastomotic structure, thrombus, ascites, hepatomegaly, and increased caliber of the hepatic veins narrowing of the IVC. On Doppler, pre- and post-stenotic gradient 3 to 4-fold, reverse or monophasic flow in the hepatic veins, and portal vein intermittent reversed flow. This is an important sign, as we can see later. This is an adult with a first day post-transplant with right hepatic vein thrombosis confirmed on Doppler and the correlation with CT study. In this case, we can identify low pulsatility flow in the intrahepatic portion of middle hepatic vein here, and height velocity at anastomotic site of the hepatic vein, almost 200, close to the anastomosis. On MRI study, we can confirm the findings of the Doppler with strictures on the right, median, and left hepatic veins. Venous outflow occlusion in pediatric liver transplant. We can treat these cases with percutaneous endovascular treatment, and the angioplasty is the first option. The stent is the second option that can be performed when we have found recurrent stenosis post-angioplasty and or initial failure of percutaneous transluminal angioplasty. Case 1. We can identify hepatic vein stenosis, a high velocity at the site of the stenosis, and low velocity at pre-stenotic site and monophasic flow. These are the velocities in a post-stenotic site, pre-stenotic site, and post-stenotic site. Here, in this video, you can see the occlusion of the medial branch of the hepatic vein. Here, the left one is okay, and we can identify short intrahepatic shunts from middle to left hepatic branch. In this case, different short intrahepatic shunts from middle to left hepatic branch vein. This is the appearance on angiography study, short intrahepatic shunts from middle to left hepatic branch, the left hepatic branch, the middle hepatic branch. The occlusion is here, as you can see on Doppler ultrasound, and the short shunts between middle and left hepatic vein. It was treated with a stent in the hepatic vein. This is the appearance of post-stent left hepatic vein. And here, this is the inferior vena cava. And in the first day post-stent, a normal velocity flow with pulsatility flow inside the stent in the proximal middle extension of the stent. Case 2. Hepatopital and hepatophageal flow in the main and portal vein branch. This is a reversed intermittent flow of the portal vein. With an inspiration, the flow is reversed, and in an expiration, the flow is inflow, hepatopital flow to the liver. A high pulsatility flow in the main portal vein can be identified in this case. Low velocity in hepatic vein, and a high-grade stenosis in the hepatic vein in the left branch. This is the high-grade stenosis, and here we can see the stent in the hepatic vein close to the right side of heart. This is the 4-day post-stent follow-up in hepatopital flow in the main and portal vein branch during the inspiration and expiration. Normal velocity flow in the main portal vein, almost 40 centimeters per second. A normal velocity flow in the stented hepatic vein. Hepatic artery complications. The incidence is up to 11% of transplants in adults. There are some risk factors related to surgical techniques. Symptoms can be negative, isolated enzymatic abnormalities, graft loss, ischemia, thrombosis, and can cause rejection. The importance of early diagnosis is to amenable to treatment, angioplasty, and vascular reconstruction. Doppler diagnostic criteria: peak velocity more than 200, tardus parvus aspect of the flow, acceleration time more than 0.08 seconds, and in cases of inconclusive Doppler, we can follow with angio-MRI or CT. Hepatic artery thrombosis. The incidence is 60% of the acute vascular complications, 3 to 10% in adults, and 8 to 19% in children. The main risk factors are cold interval and mismatch between vessels calibers. The hepatic artery thrombosis is the second leading cause of early graft failure. Early diagnosis can decrease biliary complications. The routine Doppler follow-up decreases severe complications and prevents retransplantations. Ultrasound Doppler specificity is 92% in these cases of hepatic artery thrombosis. This is a case of hepatic artery thrombosis. In a B mode, we can see here the hepatic artery, the portal vein, and the IVC. On Doppler, there is no flow in the hepatic artery, confirmed by MRI angiography and with conventional angiography. False negatives of hepatic artery thrombosis. It can cause it by some situations of marked reduction on arterial flow in cases of liver edema, systemic hypotension, severe stenosis, rejection, and exam conditions in bedside scenario. And in these cases, contrast-enhanced ultrasound can be used to identify the flow of the hepatic artery. The echo-enhanced contrast agents. In this paper, the authors did a comparison of conventional and microbubble contrast-enhanced ultrasound, and in conclusion, contrast-enhanced ultrasound helped improve flow visualization in hepatic artery and portal vein, decrease scanning time, and correctly differentiate between thrombosis and a patent artery in patients without hepatic artery flow at conventional Doppler ultrasound. Brazilian experience with contrast-enhanced ultrasound. The perfluorocarbon exposed sonicated dextrose albumin, called PESDA, is available since November of 2004. Sterile manipulation of this contrast for different studies: pancreas, liver, kidney transplants, focal liver lesions, and carotid studies. Definitive was approved by Anvisa for liver, kidney, and echocardiography studies in 2007. We performed about almost 250 exams but it was removed from Brazilian market in November of 2008. The complications are minor complications such as headache, lumbar pain, cough, and dyspnea. This is a case of hepatic artery and the cross-sectional view of portal vein and the hepatic artery, main hepatic artery with contrast-enhanced ultrasound. The left branch of hepatic artery, the portal vein. Again, we can see the main hepatic artery in a cross-section view and the branch of the left lobe, the branch of the segment 4. In this case, there are no enhancement of hepatic artery on early phase and late phase enhancement of collaterals. Here we can see the time, the elapsed time of injection, 25 seconds. And later, with contrast-enhanced ultrasound, we identified intrahepatic arterial collaterals with tardus parvus flow in the left branch of hepatic artery. This is the portal vein, and there is no flow in the arterial branch of hepatic artery. In summary, ultrasound is the first imaging modality for follow-up liver transplantations. It's an important tool to determine the most appropriate imaging method or management for complications. It can detect early and delayed vascular complications. Contrast-enhanced ultrasound is a useful tool and improve flow visualization of hepatic artery in patients without flow at Doppler ultrasound studies suspected of thrombosis or stenosis. My acknowledgement and thanks to Professor Berg Goldberg, Fleming Frosberg, Jimmy Liu, Dan Merton, Giovanni Cherry, Maria Cristina Chamas, Roberto Meirelles, Telésforo Baquela, and Francisco Carnevale for these materials. Thank you.